What's up, everybody? This is Free Game Anesthesia. We're coming to you with our first lecture ever, talking about Obstetric Anesthesia 101, and we're going to focus on maternal physiology for this one. So let's get into it. This is the ABA exam content outline with the keywords about maternal physiology. And restructuring that to make it a little bit more easily understandable for my brain, because my brain doesn't work like the ABA's. We're going to structure it. We're going to start with the cardiovascular system, go into the respiratory system, GI, heme, renal, talk about the placenta, and then get into the effects of pregnancy on the uptake and distribution. So we move cardiovascular first with a couple keywords that we want to focus on. So let's start. Overall, big idea about the cardiovascular system in pregnancy is it's a hyperdynamic circulation, and it is a state of relative volume overload. I think that's important to know because every person that I've known that has ever been pregnant says that they feel full, or like their body, things swell, their fingers get bigger, stuff like that. So if you just think overload and hyperdynamic circulation, I think that will go a long way to help you in understanding the cardiovascular system. Normal physiologic changes with that, we are going to think hyperdynamic circulation. So we're going to increase our heart rate, our stroke volume, our cardiac output, because we're creating a human right now. And we're going to decrease our systemic vascular resistance to help facilitate, get that cardiac output out. And we are also going to decrease our blood pressure a little bit, and all that is primarily going to occur because we're going to have all these hormones floating around the body like progesterone. Common question that I've gotten in the question banks is, when is cardiac output the highest in pregnancy? And that is during the second stage of labor and immediately after delivery. Immediately after delivery is associated with the auto transfusion. So when the baby comes out, all that blood, as the uterus constricts down, comes back into the body, and you get an auto transfusion. Important note about the regulation of uterine blood flow is that there's no auto-regulatory ability for uterine blood flow, and flow is going to be dependent on maternal blood pressure. Aortic cable compression, very important, because this is the reason why we do left uterine displacement for our patients, and that's when you lay a patient flat, you're going to have a baby laying on the IVC. That's not good in any situation. So when the uterus is lying on that IVC, you are going to decrease your preload, decrease your stroke volume because you have decreased preload, and decrease your cardiac output, which is bad, very bad. So you want to lean them off a little bit to the left so that you offload that uterus and you're not putting as much pressure on the inferior vena cava or IVC. Respiratory system in pregnancy, important things to note: that there's a risk for airway edema. There's potential difficult airway because of this airway edema and them being a little bit more swollen, and they are at increased risk of desaturation because you are going to have increased oxygen consumption and decreased FRC, or functional residual capacity. Going into respiratory changes, airways. Hormones basically engorge the body. We talked about that in the cardiovascular section, but this also affects the airway. And it's also important to note that Mallampati scores are typically going to increase during pregnancy. A note about oxygen consumption and CO2 production is that the body's going to produce a lot more CO2, because instead of one person producing CO2, it's two people producing CO2 and two people using oxygen. So you're going to increase both of those. Getting into lung volumes and capacities, as you can see, hopefully if you get to a test and you forget everything I've ever said, hopefully you just remember these boxes where, as far as lung volumes and capacities in pregnancy, our tidal volumes are going to go up, our respiratory rate is going to go up, and our minute ventilation is going to go up, and that's to facilitate blowing off all that CO2 and getting more oxygen into the blood. we are going to decrease our functional residual capacity, our residual volume, and expiratory reserve volume because we are going to have displacement of our diaphragm by that gravid uterus. And it's important to know, if you just remember the FRC decreases, the two parts that make up FRC are residual volume and expiratory reserve volume. So if you can remember that just FRC decreases, you can get the other two. Things that are going to be unchanged, important to remember: total lung capacity is not going to change. FEV1, FVC, and the FEV1 FVC ratio is not going to change, nor is the closing capacity. Pearls about ventilation and everything. Overall, this is going to be a incompletely compensated respiratory alkalosis in pregnancy, where your PCO2 is going to be about 30. Even though you're having that increased production of CO2, you're blowing it off because you're increasing your respiratory rate, your tidal volumes, and your mental ventilation. And your PaO2 is going to go up and it's going to probably be around 105, something like that. Moving on to the liver and the GI system. The liver in pregnancy, basically you're going to have a mild decrease in serum albumin due to expanded plasma volume. And important to know, very important to know about the GI system in pregnancy. Pregnant women are an aspiration risk. I don't know how loud I can scream it right now. They are an aspiration risk, aspiration risk, aspiration risk. They are automatically an ASA2, and they are an aspiration risk. Specifically because we are going to decrease their lower esophageal sphincter tone because of progesterone, and that gravid uterus is going to push upward on the stomach and cause increased intragastric pressure. Both things that can place these patients at risk for aspiration. Important to note that gastric acidity isn't going to change that much, and gastric emptying will only be delayed during labor. Moving on to heme. We are getting ready to bleed. We are getting ready to bleed. We are getting ready to bleed. During pregnancy, women are going to become hypercoagulable because they will need to use all of that after the baby is out, and they need to coagulate. And it's going to be a state of relative anemia, and you will see why in just a second. Going on, this is what they have on the content outline. Is just renal. So I'm not going to go too in depth. Basically, we are going to have an increased GFR and an increased renal plasma flow. This will result in a decreased creatinine, and also important to note that our normal creatinine in pregnancy will be around 0.5. Following up, the placenta, I'm going to address these things on the ABA content outline, except I will not address barrier function because I've never really seen a question about the barrier function of the placenta. So we will just kind of strike that from the record. Placental blood flow. You're going to have one placental vein that is red because it carries the oxygenated blood. You are going to have two placental arteries that carry blood away from the baby's heart, and those are going to be carrying the deoxygenated blood And also to remember that this is dependent on maternal blood pressure because our uterus and the placenta do not have any ability to auto regulate flow. Moving on, effects of pregnancy on uptake and distribution. It's very vague on the content outline. Doesn't really make sense to me, but we will get into it. And this is the last slide, so we're going to go into it. We are going to say pregnancy is going to decrease your MAC requirements, so you won't require as much anesthetic. But it's also important to know that many of the drugs that we're going to give are going to be able to cross that placenta, and things that are going to promote passage across the placenta to get to baby are the concentration gradient. If mom has a lot and baby has a little, it's going down that concentration gradient, vice versa. So that's the most important thing. Low molecular weight will also facilitate this. High lipid solubility will, and the fact of a molecule being non-ionized, because that will also promote passage. So, y'all let me know how y'all like this. I appreciate you if you watch this in any capacity, and I just hope that I can help you out. See you next time on Free Game Anesthesia.